Hi everyone, welcome to ResearchMD.com. Another great presentation today, another important topic. And before we go to our topic, let me introduce myself. My name is Dr. Pramil Cheriyath. I'm a physician and program director, internal medicine residency, transitional residency, and I'm an associate professor of medicine in two large medical schools in the United States. So we're going to teach you about what happens in the thyroid hormones in pregnancy. It's a completely different ball game when it comes to thyroid hormone in a normal person and a normal female versus a person who is going through pregnancy. That's what we're going to teach you all about it, okay? So let's look at what happens the first step. First thing we need to know about thyroid binding globulin, which is also called TBG, okay? So what does it do? Just it can make like two things in pregnancy. One, it increases thyroid binding globulin or TBG silylation process. It add a silyl group to that thyroid binding globulin. Okay, so that what it does is like it decreases the degradation of thyroid binding globulin, increase the half-life. So when you have those two things happen, you can have like increased free T3 and free T4 in the body or in the blood. Okay, the next thing it does is like it goes to the liver, because then what happens in the pregnancy, there's increased estrogen level. Okay, that is the main thing. Increased estrogen is do like two things. One, it increases the thyroid binding globulin silylation. Okay. The second thing it also does is like it enhances the production of thyroid binding globulin from the liver, and then it makes more like free T3 and T4 get attached to it, and so the level of T4 and T3 can go up. Okay. Remember, two things happen because of the estrogen level during the pregnancy. Okay. The next thing we have to look at the role of beta HCG or human chorionic gonadotropin. And so what happens in the pregnancy, especially in the first trimester, what happened? You got like increased beta HCG level goes extremely high, right? They have this, if you look at their beta subunit, they have the receptor pretty much similar to TSH. So what do? They go and bind to the TSH receptor and act like TSH. So what does it do? Your free T3, 4, and your T3 and T4 level goes up. Okay, so remember the beta HCG and they have the beta subunit. They have the similar properties just like TSH, and it can act like a TSH receptor and bind to the TSH receptor and stimulate the production of T3 and T4 in the blood. Okay. The third thing it happens is you got like increased plasma volume, so there is increased T3 pore size will increase in the body. Okay, and then you got type 3 deiodinase activity from placenta. If you look at it over here, what happens is like you got increased the placenta, there is increased type 3 deiodinase activity, there's going to be increased degradation. Okay, there is increased degradation of the T3 and T4, and that put like a lot of pressure on the thyroid gland, making the increased demand, right? And then that will increase T3 and T4 production. Okay. Now the next thing is that we need to know about the renal iodine clearance. Two ways it can happen. What happens in the placenta? Placenta uses a lot of iodine, and it also makes urinary losses of iodine, so it goes down. So what happens is like it mainly affect the females in pregnancy who has iodine deficiency already. That can decrease the T3 and T4. And the next thing we need to know about thyroid peroxidase antibodies. If you look at the females, if you like 100 females, and then the prevalence of anybody having anti-thyroid peroxide antibodies is around like 16%. What happened in the pregnancy, there is like, immunosuppression. Everybody know that. That will decrease the thyroid peroxidase antibodies. Remember that. And the last thing we're going to talk about is the thyroid enlargement. What happens when you have thyroid enlargement? You can have the increased thyroid globulin. That's in that case it can happen. Okay, so let's look at so how can we measure what are when you look at the lab values? The most important always big TSH. Okay, be careful about measuring free T3 and T4. If you wanted to measure free T3 and T4, you have to use this method called solid phase extraction liquid chromatography tandem mass spectrometry. That's the most accurate, and a lot of places don't have it, okay? So the best thing to do, the most accurate measurement for thyroid function in pregnancy is TSH level. Remember that. The reason for that, when you have high circulate thyroid binding globulin and a decreased level of albumin, that decreases the reliability of the normal immunoassays we use in regular labs, okay? Remember that. So TSH is the most accurate way you can measure the function of thyroid gland in pregnancy. And let's look at the values, like what happened to the TSH. The TSH in the first trimester, you got 0.1 to 2.5. That is the level. Okay, it's different than the normal females. In pregnancy, you got like a lot of other parameters you have to look at. In the first trimester, it's going to be from 0.1 to 2.5, because we already talked about first trimester, what happened. There's like beta HCG, right? When you have beta HCG, they got this receptor, they bind to similar to the TSH receptor. Free T3, 4 and T4 goes up, and there's negative feedback, and the TSH level goes down. So that's what it's reflecting up here. And so your parameters is from 0.1 to 2.5. Okay, remember what happened in the second trimester? TSH level slightly go up, so you go into 0.2 to 3. That is a normal level. Okay, and then you got the third trimester is between 0.3 and 3. That is the normal for that. So it's different than the normal females in pregnancy. Please use this scale to measure the TSH and look at the importance of TSH. Okay, so let's summarize everything one more time. There are three major things happening in pregnancy. One is the level of estrogen that increase thyroid binding globulin silation, decrease degradation, and increase the half-life, and the estrogen that also make hepatic thyroid binding globulin increases. Okay, the next thing is the human chorionic gonadotropin beta SC, similar to TSH receptor, bind to it, increase free T3 and T4, and then increase plasma volume that increase the free T3 and T4, and then type 3 deiodinates activities from placenta, so more degradation, and then more pressure on the thyroid gland, free T3 for protection, and then renal clearance. Placenta uses a lot of iodine, also happens is urinary iodide loss, and the patient with the females with the low iodine is they can have free T3, T4, and the thyroid peroxidase antibodies. The normal prevalence is around 16%. In pregnancy, it goes down because of the immunosuppression happens in pregnancy. And the last thing is there is like thyroid enlargement, the thyroid gland, so the increased the thyroid globulin happen in that case. Okay, so in the lab values, always pick TSH, because normal assays, because of the high circulating thyroid binding globulin, decreased albumin, it may not be accurate. You need this highly specific solid phase extraction liquid chromatography. A lot of labs don't have it. If you have this, you can measure the free T3 and 4. But unfortunately, most of the labs don't have it. So what we have is like we have to use the TSH. That's the most accurate way to measure thyroid activity, my friends. In first trimester, you got a low value. That is a normal 0.1 to 2.5. Second trimester 0.2 to 3, and the third trimester 0.3 to 3. Thank you so much for watching. We'll be back with another presentation soon. Please subscribe to our channel. Have a blessed day. Thank you.